Bellinger.
So they have presentations on basic disease. All right, so we're going to define it, give the pathomechanics, give the signs and symptoms, cover tests and measures, compare to other differential diagnosis, go over the rehab process, and discuss the outcomes, and give you an overview.
So overall, like, what is Baastrup's disease? Is that another name for it is also known as kissing syndrome, as was stated in Dutton. Dutton also defined it as an abutment at the posterior aspect of the adjacent spinous processes, one within the lumbar region. This usually occurs more like when individuals have pain going more back into spinal extension, and some of the causes that it said was due to like the overall shape of the spinous processes there, depending on how much lumbar lordosis that they had, as well as degenerative changes within the spines that were affected. And it didn't really say what an abutment was, but at least one source that I could find, it basically says that like when two adjacent spinous processes, or even if it's like a herniated disc within the spines that are affected, will protrude out against the spinal cord, but still kind of leave like a space behind, like between the spinal cords. It's not quite like pushing up on it, but it's still like near it. And then for the pathomechanics, Dutton also said that it was kind of a bit of a controversy on if about this condition, rather if it was actually just a pathological condition at all, or if it was like just due like to aging, which is why it did say that the epidemiology of it was difficult, because it also stated in the textbook that it can affect both older people and younger people as well. But the main issue that other than age that happens with this disease is that it's due to the decreased height within the disc. There's also some issues with the apophyseal joint orientation, the lordosis as stated earlier, and they also have some issues with extension within the spine as well.
All right, so some signs and symptoms. Some symptoms would include a patient may report that they have low back pain that worsens with extension. They also may report some tenderness over the affected areas. They may also, well, there may be edema or swelling in the interspinous ligament between the affected spinous processes, and a sign would be losses in range of motion. Some functional limitations would include low back pain that makes it difficult for someone to walk and stand for a prolonged period of time, and it may even come with altered posture. High impact physical activity can make symptoms reproduce or worsen, making it difficult for someone to participate in physical activities. Although pain is mostly worsened with extension, bending forward and lifting objects can also cause discomfort in the lower back. Sleep disruptions are common due to the persistent low back pain.
And then some tested measures from some different sources that was found is some of the main imaging ones. You have CT scans and X-rays. So with the CT scans and X-rays, these are going to show tests that show contact between the adjacent spinous processes of the vertebrae, which shows the enlargement, flattening, and possible sclerosis of the opposing interspinous surfaces that are shown as a result. Next, you have your MRIs, which these actually show more the fluid within the area, within the bursa there, as well as the posterior central epidural cyst, which can further show if there's like a compression on the thecal sac there. That's more of a posterior compression. Of course, you always want to assess passive and active range of motion in the area that's affected, as well as MMT and STT palpation as well, due to the condition of this disease. And then at least one source that I found said that you could do the Stork standing test, which that's also used for, it was on another presentation, I think it was the spondylosis, but fact check me on that just in case. So when they do the Stork standing test, the patient stands on one leg with the sole of the non-weight bearing foot resting on the medial aspect of the knee of the weight bearing limb. The patient is then instructed to keep this position and then simultaneously performs a slight lumbar extension movement, and the test is performed on both sides of the body, of course that being bilaterally. Then if the patient complains of pain in the lumbar region, they go into extension. This is usually related more to the pars interarticularis region. And then just some of the differential diagnosis that we were able to find. We found degenerative disc disease, the spondylolisthesis, and spondylosis. So with the degenerative disc disease, this basically occurs when there is a deterioration within the cushioning of the spine. Usually occurs within people over 40 years of age, where they start to have some of the spinal degeneration within their disc, and of course, as that padding between the discs starts to go away, the discs start to rub on each other. And this first picture is showing some of the different types of disc herniation, and the second to last one is the degenerative disc disease, which also, with degenerative disc disease, this can also lead to some other pathologies within people, being scoliosis within adults. You could also get a herniated disc, spinal stenosis, and spondylolisthesis, which leads us to spondylolisthesis, which this occurs when the vertebrae start to slip out of alignment on each other and will compress on the vertebra that's below it. And this is usually, it can also compress on nerves around the spine that are within that area and cause other symptoms of back pain. And it can occur within all areas of the spine, but the lumbar spine is the main area where it occurs. And then with spondylosis, this is where it's similar to osteoarthritis within the spine, but it's usually more due just to a wear and tear of aging within the spines, usually where it causes aging on the soft structures there that help make up the spine. And you'll usually see this one in the lumbar and cervical spine, but it's not as common in the thoracic spine due to the rib cage given stabilization. And these were just some other pictures of the spondylolisthesis, and then that was with the spondylosis. And then Dutton also mentioned a little section on some treatment that people can have. One way that they can do so is the intraspinous ligament injection, which can either be by local anesthesia or steroids. Some other ones they can take is muscle relaxants, as well as along with analgesics for that. And it did also say that they could do spinal flexion exercises to help with the pain too. And then if there's any hypermobility within the area that's affected, you would want to do mobilize the joint hypermobilities in the area.
All right. So rehab for this disease usually begins with conservative management. Surgery is typically not necessary unless symptoms are unresponsible to the non-surgical treatments. The rehab process will begin with mass protection phase, which lasts 4 weeks. The goals in this phase are to protect the affected spinal structures, reduce inflammation, control pain. There may be an incorporation of isometric exercises and even gentle range of motion exercises like pep tips, as you see in the picture. It's important to use modalities that would decrease inflammation and manage pain. For the moderate protection phase, as lasts 4 to 8 weeks, the goals are to strengthen the lumbar and core muscles, make improvement in range of motion, and increase spinal stability. The rehab process would include activities that will not place a lot of stress on the lumbar region, such as low impact cardiovascular exercises like walking or stationary bike that you do first get in most of the time. It would include strengthening and stabilization exercises for the glutes, core, and lower back, as you see bridge right there. And again, modality leads to decreased inflammation and managed pain. The minimum protection phase, they want to enhance endurance needed for ADLs and recreational activities and return to full function. The patient will be progressed to more advanced core exercises like planks or dead bugs or bird dogs, as you see in the picture, just more functional activities. This phase will include other functional training that aligns with the patient's daily activities, whatever they do for a living. In all three phases, of course, it is important to include patient education, informing them why you're doing what you're doing, and just everything about the rehab process. Our potential outcomes is hopeful and the expected outcome for the patient to avoid any type of surgeries. With most cases of facial disease, that's the case. So since PT focuses on strengthening and stabilizing, this will in turn help improve and increase daily function, which helps reduce the risk of reproducing symptoms. Quick overview, facial disease is known as kissing spine disease and results in the loss of this height. Some common causes are aging and spinal degeneration. It causes low back pain, tenderness, and losses in active range of motion. It makes it difficult to walk, stand, participate in other physical activities. And intervention focuses on improving function, so that will in turn help decrease pain and improve quality of life.
And these are our references.
So, on your spine exam, you will see some intervention questions because you have rehab components built into your presentation, right? So with your questions that you may see pertain to rehabilitation and intervention, you have to use knowledge from your content that was delivered in your presentation, but also in Dutton. So your answers are not gonna be like directly given to you. You have to extrapolate from what you know. So now, I'm gonna give you an example. Okay. So now you have to extrapolate from the content that was presented and the content that is in the book. So you all on the written exam, was it written exam 1 in this class? So written exam 1, some of you all struggle with interventions because you struggle with extrapolating content. So for example, which of the following sleeping positions should the PT recommend for a patient diagnosed with Baastrup's disease? So if you look at those answer choices, which would be the best answer choice? What's the best answer choice?
D.
Why you say D?
You know that the legs, it's gonna give a posterior tilt and it's gonna put the lumbar spine into flexion.
There you go. Yes. So now, this is basically how you have to think through your intervention questions, okay? So you have the knowledge, you have the content, now you just have to think through it. So even with your interventions, where your intervention is gonna probably be interventions that are based on what you would do in a maximum protection phase, moderate protection phase, and minimum protection phase, you have to think through those. Okay, which exercise is least aggressive and that this patient would benefit from? So now you gotta extrapolate from what is gonna increase pain or what is gonna relieve pain. Then you gotta apply what is least aggressive, what is most aggressive to the different phases. So it's not cookie cutter, you gotta think through it they're all application, okay? So I want to point that out and point this out to show you how you can see questions pertaining to interventions based on the content. So you all able to put it together. So this is how you're gonna have to put it together for your exam. So as you go through these conditions, think about what you would do and what you would not do with these patients with these conditions, okay? So that's how you want to be thinking in your studying, and you're going to perform better on your written exam once you start thinking of how you should be studying when you are studying these different conditions. All right, does that make sense? So if you study a condition and you know that forward bending of the lumbar spine is going to increase pain and aggravate symptoms and reproduce symptoms, well, you know you're going to avoid that as an intervention. And so they have a posterior lateral bulging disc or a herniated bulging disc. You know you may start with some prone exercises, some prone line, or something where their spine is in extension. Because if you have them doing forward bending type activities, that's probably likely going to increase the bulge and increase the symptoms. Okay, so this is how you want to be thinking about all your conditions. So when you go through them, study them, look at your clinical manifestations, look at your functional limitation, and align those with the phases of rehab. Does that make sense?